other sessions. We'll start off with a mini didactic with a fantastic guest speaker I'll tell you about in a second. And then we will spend the rest of the time with a case discussion of a challenging case where all of us could provide input. And we also have an interprofessional group of geriatrics experts who can weigh in on that as well. But ECHO is all teach, all learn. So we learn from each other, we learn together, and that's what makes us continue to improve the care of older adults. So I'll go ahead and introduce our speaker. And if you haven't had a chance, please introduce yourself in the chat so Dr. Braun knows who's here and so we can get to know each other. But Dr. Kevin Braun has been coming to Project ECHO Geriatrics since I believe the very first session in January of 2016 and has been on the vast majority of sessions. He is a family medicine physician and a faculty member at the Providence St. Peter in Olympia residency program. He leads their geriatrics curriculum and does some wonderful things with that, and has been a wonderful partner in learning. I've learned a lot from him over the years as he participates in these sessions, presents cases, and shares case presentations with residents. So thank you, Dr. Braun, for being willing to speak today. He's going to be talking about aging skin. And this is, of course, a very important topic that impacts all older adults and all of us taking care of older adults in primary care. So go ahead and take it from here, Dr. Braun.
Super, thank you. So tech-wise, am I, all right, let me get my...
Looks perfect.
I'm going to try my presenter view. All right. First and foremost, thank you so much for the opportunity. I have been a longtime listener, but first-time caller, but a big fan of everything that Dr. Bennett does, as well as her wonderful panel. And I will not leave out Amy Verrill because she posts these to the website. And I use the didactics extensively in teaching of my wonderful residents. And so I'm going to go very quickly and have tons of slides, far more than I was really allowed to do. But I feel like different people learn in different ways. And so this will be reference material for you to learn from, and I will talk exceedingly fast. First and foremost, what this presentation is not, I am actually not a dermatologist, but I am known as the derm nerd or derm geek on our faculty, and I have a tremendous interest. And yes, this is important for everybody who actually has skin, who is a patient of yours. What this presentation is not, I am not going to tell you how to turn back the time. This is not an anti-aging presentation, and I ask you to ask yourself whether anti-aging is in fact ageism. And unfortunately, I won't tell you how to add revenue to your practice, but there is an anti-aging and age management medicine group out there, and I stay on their mailing list mostly just to watch what our patients are being told. So what I would like to cover is what are age-related changes to the skin, and those can be either intrinsic versus extrinsic aging. Intrinsic aging is something that happens to everybody and is physiologic, but extrinsic aging are changes that result from factors that we can modify, such as UV light exposure or environmental pollutants like smoking. Sun exposure contributes to a decline in dermatologic integrity, leading to skin that sags, breaks, bruises, itches, has trouble healing. Ultraviolet light also accelerates the intrinsic aging in sun-exposed areas of the body. Lots of these sort of big table slides, and I provide them for your information, but I'll kind of highlight specific things. The decrease in skin lipids that form really leads to the development of dryness, as does a reduction in the number of our sebaceous glands. And I'd also draw your attention to reduced support for blood vessels, leading to the purpura that we see in our older patients all the time. Trying to understand the anatomy, I think, really is helpful here. And I would lead you to the epidermis here, noticing that there's a decrease in the depth and number of the ready ridges. And what that does is allow the epidermis to slide across the dermis. And so there's decreased shear force resistance, leading to these purpura and easily torn skin. Epidermal atrophy can be somewhat attenuated by sun protection. The dermis changes are significant also. The dermis will thin by about 20%, and its collagen content decreases, and there's decreased vascularization that occurs, and that causes our problems with wound healing. And there's also an actual disorganization of the collagen matrix that persists. And in another slide, just trying to show you what happens, but you get a disruption in some of the corneocyte, even though there's an overgrowth of corneocytes. And so there's decreased skin barrier. We also have decreased fibroblast. Our fibroblasts become somewhat senescent, and so they're less able to heal. And we also have decreased Langerhans cells for immune surveillance and subsequent infection fighting in our skin. Some of the melanocytes will drop out or become senescent, and that's why when we get older, we have a decrease in about 20%, so we have paler skin. Sun damage can be either hypertrophic or atrophic in its effects, and so UVA and B protection is very important. Your patients may ask you about tretinoin prescriptions, because this can reverse some of the solar changes. It leads to a thicker epidermis, deeper ready ridges, and increased capillary number with a normalization in some of the matrix proteins, right? So it's the fountain of youth that your patients may ask you to prescribe, but it must be used in higher concentrations for longer periods to have this beneficial effect. The sun is responsible for a lot of different damages that I can't go into in depth, but I would call your attention to some specific findings that people need to be able to recognize. These are called venous lakes, and they can either be on the cutaneous or the mucosal areas of the lips, or even right on the vermilion border. I've talked a little bit about these senile purpura that we get in our patients and how vulnerable they are to them, either from changes in the skin or from the medications our patients take. But I'd also ask you to just pay attention to these findings of these kind of large pore-like things called solar comedones. We also get solar elastosis of the skin. And when it's found kind of around the mouth, you'll get these sort of lemon skin presentations. And also when people have been out in the sun and their neck has been exposed, they'll develop solar elastosis on the neck, producing what's called the rhomboid wrinkle. So again, please notice that xerosis is an incredibly common finding in older skin population on a simply physiologic basis. And from a pathologic basis, I'll call your attention to pruritus, which is particularly problematic in our older patients. So ichthyosis is basically this profound dryness and scaling of the skin. It can even look sort of like fish scales, and that's where we come to call it ichthyosis. This hyperxerosis of the skin can become irritated and have some redness associated with it. And then it can even crack and develop these fissures. And when you have all of those findings together, you have what's called asteatotic eczema or eczema crackle, where the skin is so dry that it's actually cracked and irritated. This happens physiologically because there's reduced water content in the skin, a reduced barrier to water loss, an increased size and number of the corneocytes, but they are vulnerable to more breakage. And so they're dry, but they also crack. There's a decreased size and number of the sebaceous glands as well as sweat glands, and reduced dermal vasculature, all result in reduced ability to retain water in the skin, which can be worsened by prolonged water exposure, harsh washing, and can become worse in the winter. So what your skin does so well, which we sometimes remove and which flags as we get older, is both an intercellular lipid as well as a film on the surface. And that can protect from noxious exposures and protect from loss of the water in our skin. I just love this picture because it shows you how intracellular lipids get secreted and become intercellular in our stratum corneum. Big wordy slide, basically urging you to have a diagnostic approach to your patients with dry skin, starting always with a good history and a careful examination, and trying to get to a diagnosis as to whether this is normal intrinsic aging or whether this is a pathology. This is also a wonderful slide that makes us aware of what are the predisposing factors to xerosis in our patients. And a lot of these are simply age-related. So we need to be aware of predisposing factors, but precipitating factors are things we can modify and help our patients with. And triggering factors are things we can ask them to please avoid. And so there are definitely endogenous causes that lead to dry skin. And our internists will be glad to find that there's internal medicine causes here too that we need to pay attention to. Some of these can actually be psychiatric in nature, and always look for drugs. It's one of our 4 M's in age-friendly care that we need to be paying attention to. I'd call your attention to diuretics, statin medications, calcium channel blockers, beta blockers, which may be a not infrequent medication that you guys prescribe. So there are factors, again, that are triggering that can make our patients more vulnerable to dryness. They may still want to participate in these activities, but we can help them by saying, look, if you're going to be out doing things you love, like gardening, is there a way that you can take breaks from the sun? If you're going to be doing contact things that's either work or hobbies, can we provide gloves that protect your skin? These are the basic principles that we recommend to try and protect dry skin and limit the noxious exposures. And this is a cartoon from the American Academy of Dermatology that really tries to help people decrease the irritability of their bathing activities. So there are other geriatric changes, such as an inability to sense just exactly how hot the water is, and a decreased awareness of the duration of showers that also make bathing really pathologic for our older people. There is a decreased sweating and body odor that happens as we age. And so I'd encourage your patients to really look carefully at how often do they actually need to bathe. These are some general preventive measures you can recommend for your patients when they're noticing that their skin is very dry. But sometimes you may want to add in some materials that can help your patients with their dry skin and replenish the lipid layer, as well as the hydrophilic sponge-like activity of the skin to maintain moisture. This is a wonderful little instrument that I found from a German publication, and I'd encourage you to look specifically at kind of monitoring your patient's skin dryness. They have this kind of way that they grade from a 0 to 4 scale, the scaling, the fissuring, and the redness of the skin. And it's not just descriptive. It should help you when you're looking to help your patients. And if you're saying that there's more dryness scaling, you may want to add a more lipophilic moisturizing technique. Whereas if there's a lot of redness and inflammation, you might want to focus more on a hydrophilic approach. This is, again, their approach to dry skin treatment. And I focus specifically on, you can use your evaluation of redness and scaling and cracking to help dictate the strength of certain treatments like urea. And if you're not having improvement, then it guides you to certain other interventions. Really quickly, lots of things can be moisturizing, but I draw your attention to humectants here. These are things that attract and hold water in the skin. Emollients can be things that soften very hard skin and can be keratolytic at high concentrations. You want occlusions to help prevent water loss. Most of the cases of really dry skin do not have a real specific diagnosis that we can treat. So we'll end up using presumptive therapy most of the time. So it's very reasonable to say, I'm going to choose an emollient, even in places where I'm not seeing a lot of change, but I'm going to help teach you how to use it and apply it to your skin to try and prevent problems. So urea is something that I very much like to use. You'll see lactic acid in here, like amlactin, and hyaluronic acids. These can be keratolytic, as we said, but they're also large hygroscopic molecules that hold moisture in the skin. We want a nice film if we're not making our own, and these can either be petroleum products or silicone is really light and really a wonderful option for patients with dry skin. Sometimes patients will come to you saying, oh man, I really have to have a natural intervention. And so they'll subject all of these things to put on their skin. Specifically, jojoba is a wax that actually is very similar to human sebum. But natural agents really have the potential to be sensitizing. They'll develop an id reaction on already irritated skin. So you might need to talk your patients off of their entirely natural approach. I'll also call your attention to antipruritics because I think pruritus is a real problem. This is a guidance for using urea, and you'll notice that as you get to a higher concentration, you'll move from simply hydrating to having some antipruritic benefit, and then you can even get a keratolytic benefit. This table has this little warning here about fissures, but actually I find that urea is one of the most benign when you have open skin, because a lot of hydrating things like acids are incredibly irritating to cracked skin. How do you get it on? Well, soak and smear is a very reasonable recommendation for all of our patients. For people with really severe dry skin, you may want to recommend wet wrapping, especially at night. But in my new favorite magazine, this is called the Indian Journal of Dermatology, Venereology, and Leprology. It has kind of a MacGyver solution for a lot of our isolated and arthritic patients that they can get from Home Depot. And as much of your medicine you can practice with Home Depot instruments, you know, you can really get a very nice application in a place that your patients otherwise have a really terrible time trying to reach. I'm going to really quickly zoom through xerosis, or through pruritus, because pruritus is a terrible problem for our patients. It is actually a nociception. It's pain. And if somebody said, I have pain all over my body all the time, you would take it very seriously. Pruritus is very difficult for our patients to present to us because their skin has a decreased erythema response. You may have itching and present with absolutely no skin lesions. It affects somewhere between 11 to 78% of our patients, and the etiology is very difficult for us to discern. So sometimes it's from xerosis, but sometimes it's from dermatologic diseases or even systemic diseases. And chronic itch has been shown in multiple studies to worsen the quality of life of elderly patients. So here's your obligatory big long list of potential causes, but try to identify an underlying cause if it exists. But senile pruritus is oftentimes idiopathic and doesn't have a really obvious cause. There are internal conditions that seem to present like this, but 50% of dermat referrals are for pruritus in elderly patients. This is an exhaustive list, but you may want to more consider the location of the itch as being helpful for diagnosis. Things like vulvar or genital itching can be a lichen simplex or even a lichen planus type of a presentation. And there are pruritic lesions that develop because of a neuropathic cause. This is a guiding slide to try and have you focus on your approach to pruritus when the patients present to you. But labs are really only indicated in patients who lack a primary skin diagnosis. Thyroid is really an uncommon cause, so thyroid tests are useful only in patients who have thyroid symptomatology, and reserve chest x-ray for patients who have B symptoms. Advanced itch labs for refractory itch can include celiac testing for anemia, microcytosis, or celiac symptoms. And for patients with abnormal liver functions, they probably could benefit from a bile acid or antimicrobial antibody testing. So these are drugs that can cause pruritus. And again, trying to respect the 4 M's of geriatric care, please pay attention to medications. There are some antibiotics that are much more likely to cause itching than others. And I've given you another good reason to hate amiodarone. As you're choosing antihypertensives, note that ACE inhibitors have a more significant risk for pruritus. And then statins are not an infrequent cause of pruritus, as are opioids. And just remember that amphetamines and cocaine can cause itching too. These are some historical and physical clues to try and get you to focus on what may be the cause of your pruritus. Something like Grover's disease may be very unfamiliar to you, but it is a small, lightly scaled pruritus that presents worse after sweating, primarily on the trunk and in inframammary folds. In addition, there are lots of pruritus that causes secondary skin changes. So this is an actinic distribution of prurigo. This is a wonderful example of lichen simplex chronicus, showing increased skin lines, well demarcated lichenified plaques, hyper or hypopigmentation, and in this case, it can be kind of erythematous and even show excoriations. These nice linear changes are really fingernail marks. People who have changes will oftentimes have sparing of the mid to upper back. That's called the butterfly sign. And especially in geriatric itching, it's a real sign that what we're dealing with is really kind of this scratch itch cycle that we want to avoid. Strange things like this prurigo nodularis will present, and you can try using high potency or ultra high potency steroids for 4 to 6 weeks to interrupt the scratch itch cycle. But remember, you can biopsy to get a definitive diagnosis. Call your attention here to some dermatologic conditions that can cause this pruritus. Atopic dermatitis is known as the itch that rashes, but you'll get lots of contact things on older skin that show a rash that is itchy. I don't have time to go into bullous pemphigoid, but it is a geriatric syndrome, very important to be able to recognize and diagnose. There are some things like lichen planus or lichen simplex that have a distribution that helps you. And remember that photodermatitis can also be a medication-related photodermatitis. Our patients may, as they age, adapt new cosmetic habits that can cause them to have contact dermatitis. They may have new jewelry or new habits like hiking that bring them into contact with things that cause pruritus. They may develop a love of working on their cars in their older age that exposes them to significant pruritic agents. They also will frequently use things like neosporin that are sensitizing, and even water can cause aquagenic pruritus. And for internists, these are your diseases that really will manifest with itching. Everybody is deathly afraid of missing a cutaneous T-cell lymphoma or the internal cancer that is a representation, but it really is quite rare. Remember, cholestasis can be medication and acute illness related as well. Neuropathic pruritus is really important to notice and will present sometimes as notalgia paresthetica or meralgia paresthetica. And these are some algorithms, if you like that, to focus on diagnosing. And this is that was an algorithm that also gets into some treatment. And then nonspecific pruritus management, I encourage you to focus on topical rather than systemic, which even includes topical ketamine. And there are lots of protocols for really specific hepatic or renal disease beyond the scope of my presentation. I'll get very quickly into, I love this because our geriatricians' work to apply the 4 M's is being adopted by dermatologists. They're trying to learn how to be good geriatricians as well as dermatologists. Here's my bibliography. Here's my evaluation. Please give me feedback so I can be better.
Thank you so much, Dr. Braun. I really appreciate the presentation. I was wondering if you'd be willing to share these slides with the group if we can send it out after the session.
Absolutely.
Great. So we have a copy and we will share that with everyone because there were a lot of